نبتدي الكلام في الشيست، وأتمنى أنكم انتوا تكونوا إن شاء الله مذاكرين، وفي نفس الوقت يعني يا ريت كل الناس تشارك، لأن ديت بتبقى مفيدة بالنسبة لحضراتكم في الامتحانات وفي الحياة العامة وكده. فاحنا هنعرض كالمعتاد بعض الحالات ونستنى الإجابات من حضراتكم then we discuss the result. Okay. Then what do you think about this chest X-ray? Anyone can answer?
Bilateral dense opacity,
yeah,
with the pleural regularity, yeah. Most likely pleural plaques.
Very good. And this is the right answer. And you see, as you have said, and also I have mentioned this many times before, if you see bizarre shaped opacities in the lungs and you can not specify the origin of these lesions, please look to the diaphragm. Then if you see these very characteristic plaques and they are frequently calcified, then you know that all you are seeing here in both lung fields is nothing but calcified pleural plaques. And the pleural plaques have many underlying etiologies, and the most common is asbestos exposure. Then what do you think of this?
Found density at the right cardiophrenic angle in the lateral view, yeah. Confirming the anterior position,
yeah.
Mostly pericardial cyst.
Very good, and this is a pericardial cyst, and you remember many times I said that this place is almost reserved for the pleuropericardial cyst, and you know that this cyst contains fluid density and it can show some marginal calcification. And you should remember that hydatid cysts in the lung do not calcify, and this is not a pulmonary lesion but is a mediastinal pathology, and you see that the patient also had a pleural effusion. The right answer, yes.
Rectus excavatum.
Very good.
There is shifting.
Yes, and
shifting of the cardiac shadow.
Rectus excavatum, and frequently this is the only projected X-ray in the exam. Then you should feel that the cardiac shadow is shifted to the left side and nothing of the heart is to the right side of the spine. Then if you are lucky enough and you have the lateral X-ray, then you can see that the sternum is the breast, and the breast sternum is compressing the cardiac shadow, which will go to the left side as you can see here, and this is Rectus excavatum.
Assalamu alaikum.
Alaikum salam.
Chest X-ray PA view.
Yeah.
Show chest X-ray PA view showing focal lung lesion of an obtuse angle, oval shape, radio opaque density based on the left lateral chest wall from inside, denoting that could be originated from the pleura because it's obtuse angle with the surrounding lung parenchyma.
Yes, very good. If it is of pleural origin, what do you think?
Could be a pleural mass like mesothelioma, if we think of a malignancy, or pleural cyst like.
Then what do you need for further evaluation?
CT scan.
Okay.
It denoting that there is pleural thickening with the destruction and erosion of the surrounding rib.
Yeah.
This is most probably in wing sarcoma if it's in a young age, and mesothelioma in an old age.
Yes, this patient is 50 years old. Then, this lesion does not look so much aggressive, but there is actually erosions, and your suggestion is right. It is not in the lung, it is of the chest wall. But considering the underlying rib pathology, then you may feel that this is of rib origin. And
Could
in
be
such,
metastasis.
yes,
Yes.
metastasis or
Or
yeah, do you hear about the rule that I have made many times ago, that if you see a lesion and you don't know the differential diagnosis of this lesion, and you feel that is of malignant nature, then you mention the primary malignancies that could be here. Then you mention immediately after it lymphoma, and then metastatic deposit. These are the most frequent three lesions coming after each other. Then the primary lesion in this location with some expansion is myeloma. Then you follow it by lymphoma, and finally you got a metastatic disease, and this has been proved to be a plasmacytoma. Okay.
Pneumothorax on the left side.
Yes, a simple or tension.
Symbol.
Simple pneumothorax. How can you
I
differentiate between
think
both?
it is pushing of the diaphragm. Now the diaphragm is not deep sulcus. Sign is not there.
Okay.
And
And the mediastinum is more or less central. Then your feeling is good, and we always think of a tension pneumothorax when the diaphragm is depressed and the mediastinum is contralaterally shifted. But if this pneumothorax is accumulating very rapidly according to the clinical condition of the patient, then you may think that is of the tension type. Bankos tumor is in the apex of the lung and is usually located posteriorly, but this is an anteriorly located lesion which is destroying the chest wall and has a component outside the chest and another component inside the chest. This is good for a chest wall lesion,
chest wall lesion.
which may be, as I have mentioned before, lymphoma, metastatic deposit, and this is not an abscess, of course, but the possibility of a bronchogenic carcinoma that has invaded the chest wall should be also kept in mind, provided that you have a metastatic node in the mediastinum and also you have a thrombus in the superior vena cava. These findings are supporting findings for this lesion to be a bronchogenic carcinoma invading the chest wall. Then, what do you think of this?
actually,
left white
So
hemithorax
Left,
showing
total
air
collapse.
bronchogram.
left, or right? Where is the lesion? Left or right?
Left.
Left.
left,
What do you think of this?
It's left white hemithorax
Yeah,
showing air bronchogram.
okay.
Total lung collapse, left side.
Where is
Shifting of the
the
mediastinum.
heart? Where is the heart?
Mediastinal shift to the
Shifting
left.
of the mediastinum.
Yes, marked mediastinal shift. Then it is a good policy if you see a chest X-ray with these ECG or ECG leads on the chest, you look for the tubes. This is very, very important. If you look to the endotracheal tube, then you can see the endotracheal tube is selectively in the right main bronchus.
Right.
Then the right lung is inflated or ventilated, but the left lung is the bronchus is occluded and there is total
Collapse.
consolidation or total collapse with shift of the heart to the opposite side. This is very important in the ICU department to get up quickly the endotracheal tube into the trachea, then both lungs will be ventilated and this will recover immediately. Yeah. What do you see? This is a diffuse lung disease or focal?
Is UIP pattern.
Yes, it's a diffuse lung disease. Which type? Interstitial, alveolar, miliary, cystic pattern?
Interstitial with cavitary.
Yes, and this is interstitial disease with cavitations, and these cavitations are nothing but cystic bronchiectatic changes. Then, if you look carefully in the subpleural lines, and you can see collections of honeycombing everywhere. And the combination of honeycombing and some bronchiectatic changes is diagnostic of interstitial lung fibrosis or usual interstitial pneumonia, and one of the complications of this disease is to get emphysematous pulmonary changes and cystic bronchiectatic changes. Then this patient is 50 years old with this opacity in the lung. What do you think?
Pneumonia.
Pneumonia.
Lobar.
Okay, lobar pneumonia. In the middle lobe, you mean?
Yes.
Yes, and there is maybe some pleural effusion,
Pleural effusion.
but if you consider the possibility of pneumonia, and you should see some air bronchogram inside the lesion. This is number one. And number two, the pneumonic consolidation, and this is very important, is usually bordered by the fissure. It does not cross the fissure. And then if you see this, and you should include in your differential diagnosis that this may be a mass. Then the CT scan of the same case showed that this is a mass with areas of breakdown and heterogeneous enhancement, as well as some compression of the adjacent lung parenchyma. Then, and you see the pleural effusion as well. What do you think?
Bronchogenic carcinoma.
A mass in the lung is a bronchogenic carcinoma, and this lesion in the liver is just an incidental finding. It shows the classic appearance of a hemangioma with nodular peripheral contrast enhancement. And you should remember this fact very well, that hemangioma, whatever it is big, it cannot deform the hepatic contour. And this is one of the signs that you feel confident with it, and you can exclude easily the possibility of this lesion to be a metastatic deposit. And this,
Cavitatory lesion, multiple cavitatory lesion.
yes, there are multiple cavities in both lung fields, and there is also a pleural effusion and some pneumothorax. Yes, what do you think?
Metastasis, cavitatory metastasis.
Metastasis from what?
Angiosarcoma.
Yes,
The
the patient had angiosarcoma of the thigh, then if you know that the patient had a primary malignancy, and you should try as much as you can to relate the findings to the primary condition in the patient. If not, then you can search for another diagnosis. But can the metastatic deposits be cavitating? Yes, of course. Can metastasis be associated with effusion? Yes, of course. Can metastases, whenever they are cavitating, one of them rupture and produce pneumothorax? Yes, of course. Then the diagnosis should not be other than metastatic angiosarcoma. And if you are asked about the differential diagnosis of cavitary nodules, there are a lot. The septic emboli, Wagner granulomatosis, and the rheumatoid nodules, and many. But in the presence of a positive history of primary malignancy, then you forget about all and you remember only the possibility of metastasis.
Bilateral diffuse interstitial opacities with the bilateral pleural effusion
Yes,
in patch areas in the right lung.
yes.
In case of a present of the prostatic cancer, it's highly suspected to be METs in the first priority.
What kind of mets?
Lymphangiocardiomatous.
Yes, lymphangitis carcinomatosa. And interstitial opacities in the current history of cancer, then you consider lymphatic spread of this carcinoma and you diagnose lymphangitis carcinomatosa. Of course, it can be associated with pleural effusion, can be associated with metastatic lymphadenopathy, and also can be associated with pneumonic consolidations. Yes.
Left pulmonary artery aneurysm.
Okay, and if you look to the chest X-ray, you see that the pulmonary artery is very big, but it is not on.
Hypertension.
Yes, this is not only the pulmonary artery, but also its main branches. And you can see this in the axial images, which are much more informative than the coronal one. And you see the huge dilatation of the main pulmonary artery as well as its central branches, and this is diagnostic of pulmonary arterial hypertension. And of course, you know that pulmonary arterial hypertension may be idiopathic without any underlying cause. But the secondary pulmonary arterial hypertension is caused by damage of the lung parenchyma in cases of emphysema, cystic fibrosis, chronic pulmonary emboli, and the Eisenmenger reaction with chronic left to right shunt.
Flail chest
Yes, with
with aortic knob distension.
no.
Pneumothorax,
Yes,
right?
and if you see rib fractures, look immediately for pneumothorax. Then, if it is not that clear, and you should have the expiratory and inspiratory films to be sure that there is no pneumothorax, but there are multiple rib fractures with pneumothorax. Yes,
Bronchogenic mass with the IVC thrombosis, superior vena cava thrombosis.
yes, and
Right bronchial invasion.
no, this is not true, but there is some encroachment on the right main bronchus, and there are some lymph nodes here. And this mass in the lung of an adult should be considered as a bronchogenic carcinoma until proved otherwise. The superior vena cava is filled by tumor thrombus, and there are some lymph nodes in the aortic window. Yeah.
Yes,
Sorry.
atresia of esophagus. What
Atresia
was that?
of?
Is that lobe of the nasogastric tube?
Yes, it is.
Is atresia of the esophagus?
No, and this is an adult
No,
patient,
no.
and you see air in the. But this,
It is displaced.
yes, this is a
Malposition.
malposition. Yes, this is right. The nasogastric tube has coiled inside the esophagus and back into the upper esophagus.
Surgical emphysema
Where?
in the neck, beside the trachea, double
Yes,
trachea
very good.
sign.
Whenever you see these lines of air in the neck, and you always think of pneumomediastinum. Then you look for the other sign, which is the continuous diaphragm sign, because you cannot see air actually in the mediastinum because of the adjacent lung. But if you want to diagnose pneumomediastinum easily, look for the neck of the patient. If you see linear air shadows alongside of the trachea, then you should think of pneumomediastinum.
There is a mass in the middle right lung, and
There is miliary shadow, reticular shadow, interstitial lung
This is
disease.
diffuse lung disease of what type?
Reticulonodular.
Reticulonodular. What do you think?
Lymphangitis carcinomatosis.
There is no positive history of malignancy.
Sarcoidosis.
there is a cavity in the middle lung.
This be a summation of shadows, but if you see a picture like this, then you say that I'm dealing with diffuse lung disease, most likely of the interstitial type, and on the top of the diagnosis will be idiopathic pulmonary fibrosis or usual interstitial pneumonia.
Yes.
If you have to differentiate this from others, then you should have the high resolution CT to look for the honeycombing, the bronchiectasis, other findings that can support your diagnosis or exclude it, and you look for another etiology.
Mycetoma, there is
Yes.
a cavity in the left upper
This
side.
is the cavity in the apex of the lung with a mass in the cavity and the halo sign, which is a diagnostic of a fungal ball or mycetoma or aspergilloma. The literature says that the visualization of air crescent sign indicates favorable outcome because these patients without leukocyte function cannot form this consolidation, and then the presence of leukocytic defense will produce such a lesion. Yes.
Rupture of breast implant.
Yes, very good. Rupture of
normal lung.
Rupture of breast.
Yes, the left breast implant has ruptured because of the trauma, and you see the reaction in the subcutaneous tissue and the small and the deformed size of the implant.
It's a fusion by
Yes, but there is a very big lesion.
a big mass. Yes, yes.
Neurofibromatosis?
Neurofibromatosis of the chest wall. Did you look carefully for these calcific foci?
Mm.
Hemangioma?
Yes, of
Multi-
course. And this is
Yes,
a
it's
very
hemangioma.
big venous malformation. The new name of hemangioma is venous malformation, and is diagnosed actually by the presence of calcific phlebolli. Whenever anywhere the hemangioma is present, and you can spot the diagnosis by these minute calcifications. Yeah.
Enlargement lymph node
Where?
in the right medius, yes, right
This
ilium.
side, and remember that this chest is not well centralized, and it is markedly rotated.
Malposition, yes,
Malposition, yeah.
yes. And there is a tube,
Yes. What is this tube?
NG tube.
I think it passed through the trachea.
What is the tube?
ET tube in the lower main
This
bronchus,
is
right?
endotracheal tube, you think? No, it's not the calcium.
Angio.
This is
NG tube.
nasogastric tube.
Gastric tube, yes.
Yes, nasogastric tube where?
In the trachea, I think.
Yes, into the lung.
In the bronchus. Yes, in the
Lower
bronchus.
main bronchus.
It has been pushed through the trachea to the right main bronchus to the base of the right lung, and this is nasogastric
NG malposition.
malposition.
Yes. There is pleural effusion in the right lung and diffuse lung
Yes, and
disease.
this is what we call subpulmonary effusion. You see the fluid level and the deobliteration of the costophrenic angle, as well as the thickening of the fissure, indicating some fluid inside the fissure, and this is subpleural
Pleural
effusion.
effusion.
Okay.
There is a reticular nodular shadowing both lung and not response to antibiotic. This may be interstitial pneumonia.
Eosinophilic.
Eosinophilic
Acute. And
or
you think
crypto.
of acute eosinophilic pneumonia?
No, too much. It's cryptogenic organ. Yes, cryptogenic organizing pneumonia.
Cryptogenic organizing
Organizing pneumonia.
Here's a local sign. Then look at the CT
Chronic
scan.
Sarcoid. Sarcoidosis.
Yes, very good. And this is sarcoid because of the multiple enlarged
Bilateral
lymph
lymph
nodes.
node.
They are well demonstrated in the CT scan, but they are masked by the opacities in the plain X-ray. And you see the reticulonodular shadows, which are extremely characteristic of sarcoid. This is what we call lymphangitic spread, where you got nodularities along the fissure, along the pleural surfaces, together with the nodes, are diagnostic of sarcoidosis.
Bilateral.
Yes, this is a simple case of a bilateral pleural effusion raising to the axilla, mild type, and obliterating the costophrenic angles.
Chest pains. This lymphangitis carcinoma.
Carcinomatosis.
There
Yes.
is no
Associated with the breast.
history يا جماعة
Breast
2018.
lesion.
Hmm?
Breast lesion, left breast.
Breast lesion.
Yes, yes, very good. And this is the breast cancer, which I advise you that whenever you have a chest X-ray for a female patient or a CT scan, please look to the shadow of the breast. If it is present, it may contain a lesion. If it is removed, and this is a sign of malignancy because the breast has been removed, and the presence of this mass with a speculated margin in the left breast together with the skin thickening and the interstitial opacities are diagnostic of lymphangitis carcinomatous.
High lymph node.
Yes. What do you think?
There is-
Minor lymph nodes.
There is F3.
Sarcoid.
TB.
No, no.
And there are 4 possibilities for the lymphadenopathy: 2 inflammatory, TB and sarcoid, 2 neoplastic, lymphoma and metastasis. If the hilar nodes are bilateral and
Not
symmetric,
sarcoid.
yes, and this is the nodes of sarcoid.
Hydatid cyst. Rupture.
Rupture hydatid cyst.
Rupture, hydatid cyst, or fungal ball.
Yes. Maybe
Hydatid
fungal.
cyst, I think it has air fluid level with the wavy
water lily sign.
rays.
Yes.
دي أقرب للأسبرجلوزس.
Yes, and this is the fungal ball, because if you got rupture of the hydatid cyst, you got air fluid level and the water lily sign. If you are confronted by a question like this, and this is not an abscess, of course, and the fungal ball is a good possibility. Rupture hydatid cyst, no. Cavitating bronchogenic carcinoma, no.
This is hydatid cyst.
Yes, very good. These are multiple hydatid cysts in the lung and in the liver. And we know the
Liver, yes.
diagnosis by these. These lesions, which are located in the lung base, they are cystic, containing clear water density with paper-thin wall, and the only cystic lesion filled with fluid in the lung is the hydatid cyst. And if these are hydatid cysts, then the remaining will be so, and also those in the liver are the same.
This is
Poland syndrome.
No,
There is no breast shadow on the left
yes,
side.
I give you a note just a few seconds before. If you are interpreting a chest of a female, be careful about the breast shadow, especially in the exam. This is one of the famous tricks in the exam.
chronic TB.
Picture of TB.
TB.
TB. You think that this is TB? Yes, very good.
This is metastasis
Metastasis of
Of
what?
thyroid.
Yes,
of the thyroid cancer.
Thyroid carcinoma.
yes, you are very good actually.
Common.
This is, if you look carefully here, and you can see some indentation of the tracheal air column by the thyroid mass, which is the clinical presentation of the patient, and these are miliary metastatic deposits. This was at the time a very frequent case in our exams. Then what do you think?
Same.
Lymphangitis carcinoma.
Yes, very good. Lymphangitis
Reticular shadow.
carcinomatosa, and you see extensive interstitial opacities in the presence of known primary malignancy, then you diagnose this. You know what you think?
No history.
Yes, you can select one of these.
Evitating pneumonia.
Yes, you are right. And I have mentioned before that pneumonia has a sharp border with the fissure. And this is a very important sign to differentiate it from malignancy and other possibilities. And this is cavitating pneumonia. And you see the cavity with some septation inside, but the inner wall is extremely smooth, as you can see, and you got some air fluid level inside.
Hypersensitivity pneumonitis. There is a ground glass.
Hypersensitivity pneumonitis do not show bronchiectasis.
Non-specific interstitial
Yes,
pneumonia.
non-specific interstitial pneumonia will show ground glass opacities, will show bronchiectasis, but it will not show honeycombing. And this is the difference between both.
This is in the horses of the voice. There is a mass in the right upper lung. This is metastasis.
No, Bankos tumor will be here.
No, this is bronchogenic carcinoma.
Yes, bronchogenic carcinoma. And
Carcinoma.
this film is intended to know that whenever you are confronted by a lesion like this, do not diagnose anything apart from lung cancer until proved otherwise, especially in patients who are smoking or they have hemoptysis and some change in the voice because of the recurrent laryngeal nerve.
Collapse.
Of
Lower lobe collapse. Left lower lobe collapse.
yes, very good. This is also a famous
Triangular
in
opacity.
the exam, a triangular opacity posterior to the heart, and in the lateral view it is projected on the spine, and this is the classic appearance of left lower lobe consolidation collapse.
Pneumothorax.
Which side?
The left lower.
The left is clear. The left costophrenic angle is clear.
Hydropericardium.
Hydro?
Pneumopericardium.
Hydropneumopericardium, but this is the right cardiac border which is free.
Hiatal hernia.
Hiatus hernia.
This is massive hiatus hernia, and it contains air fluid level, of course, because the stomach is totally herniated in the hernia, and the gastric contents will form this this fluid level.
Emphysematous.
Medial left upper lobe.
Yes.
Left upper
Bronchial sign.
Yes.
Bronchogenic carcinoma.
Yes. In any adult, if you see a mass like this, 3 centimeter or more, you should not go for any diagnosis until proved otherwise.
Metastasis.
Cannonball, metastatic deposits. Sometimes they do not provide this history, but the presence of the central venous line, which is usually used for chemotherapy administration, is sometimes a clue for the history.
Fever and cough.
Bankos tumor.
TB.
Please remember that Bankos tumor is centered at the apex of the lung, and you cannot diagnose Bankos unless you are able to see some destructive changes in the rib. You may suspect the lesion, but you are not sure unless you have this. Okay.
Rupture hydatid.
Rupture hydatid cyst with the classic water lily sign and the collapse of the endocyst.
Lymphocytic interstitial.
Lymphocytic
And you know the diagnosis
interstitial
from
pneumonia.
the history, but you should look for the CT scan and you see these cystic changes in the lung, which is diagnostic, as you have said, of lymphocytic interstitial pneumonia. Very good.
hilar lymph node in the right. There is lymphadenopathy in the hilum,
Yes.
the right lung. Yes.
And what do you think of this?
Collapsing.
There is some reticulonodular infiltration here, some loss of volume of the upper lobe, and the prominence of the hilar chakra
Post-primary TB.
to be. Okay.
Cough and shortness of
Usual interstitial pneumonia.
Yes, very good. Usual interstitial pneumonia, honeycombing, traction reflexes,
Diffuse
vastus, and so on.
left side of the fusion.
pneumothorax.
No,
Pneumothorax.
Pneumothorax.
no,
Mesothelioma. Fusion.
no.
Left side.
There is pleural effusion, okay, but you see this very big mass in the mediastinum. Yes,
Pulmonary edema.
pulmonary, the lung is clear. The lung is clear, but this mass is a mediastinal mass. And the mediastinal mass, which is central in location, then you may...
Aortic aneurysm.
Retrosternal goiter.
Okay.
Lymphoma.
Okay, then let us assess all the possibilities. Retrosternal extension of the thyroid, if you see the upper border of the mass, this will exclude this possibility because in retrosternal extension, you cannot see the upper border of the mass. Then the other possibility of lymphoma is a very good possibility because there is a big mass on either side of the mediastinum. If this is an aortic aneurysm, it will be located on the left side and centered to the region of the aorta. Yeah, broadening of the superior mediastinal shadow in the pediatric age group and in adults is almost always suggestive of lymphoma until proved otherwise.
Thromboembolism.
Vasculitis.
Vasculitis.
Lymphoma. Calcified lymph nodes.
Calcified
Calcific lymph nodes.
And this is the IVC. Then you go to the pulmonary artery and the
Calcific lymph
nodes. And inside the nodes, you got some calcium.
Calcification.
Then what are the nodes that can calcify?
infection, TB or sarcoid.
Sarcoid. These are the only possibilities. The nodes that can calcify, these are the tuberculous nodes or the nodes of sarcoid. But sometimes the nodes that are metastatic from bone tumors like osteosarcoma or chondrosarcoma may calcify. Okay.
Deposit.
Yes, metastatic deposits, breast cancer.
Pleural effusion, the right lung. There is a mass outside.
Another effusion here, but if you look carefully to the surface of the effusion, it is not the crescent sign. It is
associated with the mass.
Upward. Then you suspected that there is a mass underneath
the
effusion, and you got a mass. And this mass is big.
It's lymphoma.
Yes.
Lymphoma.
Yes,
Non-Hodgkin.
the aorta, the floating vessel sign, pleural effusion, and this was proved to be a follicular lymphoma. Very good.
Hemomediastinum. Normal.
right hilar shadow.
Right hilar shadow.
Deep sulcus sinus of left costophrenic angle.
No.
Normal.
Normal, I think there is some malposition.
Normal.
Yes.
Look at the breast shadow.
Yes,
the breast is missing on this side, and you got a sclerotic deposit in this rib. Okay, and I gave you this notice many times before. If you are looking for a chest X-ray or CT of a female patient, look for the breast shadow, especially in the exams. And here there is mastectomy, and that's why there is hyperlucency here. And if you look carefully here and you see a sclerotic lesion in this part of the rib, and this was metastatic deposit.
Hiatus hernia?
Yes, very good. And this is now a simple question. And you see that the hernia in the GI module, we have 4 types of hernia, and this is type 4. Sorry? Okay. And this is a huge hiatus hernia containing colon as well as the stomach.
Hamartoma.
Yes, very good. This is pulmonary hamartoma, smooth margin with popcorn recalcification, and this is diagnostic of hamartoma.
Pneumothorax, right side.
Tension is simple.
Tension.
Yes, this is tension pneumothorax because of the depression of the diaphragm compared to the left one and the shift of the mediastinum to the opposite side.
Thromboembolism in the pulmonary artery of the right main bronchus.
And here you see this filling defects, and also you see filling defects on the left side. Very good. And this is the cryptogenic organizing pneumonia. This is the classic appearance.
There's Hammerstein.
The history is good for the diagnosis, even in the absence of the reversed halo sign. But
دكتور الهالو ساين شرط موجود له اعتياد اذا ما موجود الهالو ساين.
No, it's not an essential finding, but the essential finding is you see what looks like pneumonic patches that do not respond to the antibiotic therapy, especially if this is a relatively I can say chronic or a lesion that is not acute. But if it is acute, then you consider the possibility of acute
eosinophilic pneumonia.
Yes.
Pancreas tumor.
There is a mass in the right upper lung.
This is fungal bowl. This is TB, of course, infiltration. And one of the manifestations of TB is the presence of fungal bowl with the crescent sign. And I emphasize the changes of TB in the lung because this is a frequent disease in our area, and it is considered one of the big mistakes if you miss a case of TB for another diagnosis. Then
there is a large mass in the left lung.
Yes, and
this is bronchogenic. This is not 16 years.
This patient is
Ewing sarcoma.
Ewing sarcoma.
This is Ewing sarcoma of the chest wall. But I have recently seen many cases that are younger than 8 years, and they develop bronchogenic carcinoma because of cigarette smoking. but we still confined to the rules that say if you got a mass, and this is actually a mass of the chest wall, not a mass on the lung, because it is almost centralized to the chest wall, then you think of an Ewing sarcoma instead of bronchogenic carcinoma. Yes.
Left-sided pneumothorax.
Tension pneumothorax.
Tension,
Pneumothorax.
tension or CP?
Tension.
Tension. Tension.
Tension pneumothorax. I don't think that this is tension, because you know that the left copula is lower than the right copula, and this is usual. And the heart is almost in the central part of the mediastinum. Okay.
Forcing dyspnea, fever, bronchogenic.
TB.
TB. Okay.
Bronchogenic
Bronchogenic carcinoma.
I swear that Bankos tumor will destroy the apex of the lung. And this is not a Bankos tumor. This is a consolidated area with central breakdown and some air loculi inside. This is infection. And the pneumonia which develop central cavitation is known as necrotizing pneumonia. It is common in the pediatric age group, but can also be seen in the old patients if they are immune compromised or they are infected by a virulent organism. Then you may got a lesion like this. It's a consolidated area of the lung with multiple air loculi inside due to necrosis. And this is what we call necrotizing pneumonia. And this necrotizing pneumonia is either because of the virulent organism or because the lower immunity of the patient.
Mass of the
Yes, and this is a mass in the adult lung should be considered as bronchogenic carcinoma, and this is a bronchogenic carcinoma.
Carcinoid.
Carcinoid.
Containing
Okay, and this lesion is pulmonary or mediastinal?
Mediastinal.
Okay. Anterior, middle, or posterior?
Anterior.
Contains the fat.
Germ cell tumor.
This is the only lesion which contains the fat in the anterior mediastinum. And you remember that no masses in the lung containing gross fat. If you see fat inside a mass and you are not sure that this is mediastinal pathology, consider it as mediastinal pathology because there is no masses in the lung containing gross fat unless extremely rare and is usually diagnosed by biopsy.
ground glass.
COVID-19.
Yes, very good. This is COVID-19 infection and is showing the classic appearances with the ground glass and subpleural lines, and this is the classic appearance of COVID-19. Yes.
Cystic fibrosis, cystic bronchiectasis.
Yes, cystic bronchiectasis, and you see multiple cystic lesions in both sides, and you got some air fluid levels inside. This means that they are secondary infected, and this is cystic bronchiectasis that are secondary infected.
Fibroblastoma, right?
Yes,
Just
to the
bilateral.
left or to the right or both.
Bilateral.
Bilateral, by more right.
But the right one is
More.
bigger than the left one. Very good. This is elastofibroma dorsi, which is an incidental finding.
Version.
Yes, this is cavitating bronchogenic carcinoma, and you see the marked irregularity of the inner wall of the lesion. You see the metabolic activity of the tumor margin, and you see the metastatic nodes that are hypermetabolic in the mediastinum. Normal chest X-ray, and this is the CT scan. Still normal?
No. Multiple lymph node.
Yes.
Lymph node, there is lymph node, yes.
Diagnosis is TB nodes are necrotic and marginally enhanced, and the sarcoid nodes are those. These are the classic appearance of sarcoid nodes, discrete, homogeneous, and sometimes they contain calcium.
Cavitary lesion for bronchogenic carcinoma?
Yes, cavitating bronchogenic carcinoma, and you see the marked irregularity of the inner wall of the lesion.
Pneumonia.
Where?
Left lower lobe.
Left posterior.
Left lower lobe. And you think that this is pneumonic consolidation behind the heart and is also superimposed on the lateral view. And then this is the CT scan and MRI.
Neurogenic mass, no?
Yes, very good. And this is a neurogenic tumor, posterior mediastinal tumor. It has a smooth margin, and you see the clear, sharp margin, meaning that this is a benign lesion, not a bronchogenic carcinoma, for example. And this is the appearance of the tumor in the MRI. Very good. Right or left?
Left.
Here?
Right hazing of the mediastinum.
Right hilar mass.
Yes, there is a lesion here.
Right hilar mass.
And if you are not sure about the lesion, then you should have a CT scan, and the diagnosis is
Bronchogenic
bronchogenic carcinoma because of the typical speculated margin.
Speculated.
Yes.
Left lung abscess.
This is lung abscess, which is acute because of the surrounding pneumonia. If you see some consolidation around the abscess cavity, and you say that this is acute lung abscess.
Pericardial cyst.
Very good. This is a pleuropericardial cyst, the usual classic location for this benign cystic lesion.
Hydatid.
Ruptured hydatid with the classic water
release sign. TB.
My stoma, left
Fungal
my
ball and the left upper.
Very good.
lung herniation.
Very good. Very good. Lung herniation. And you see this part of the lung, which is outside the thoracic cavity, and by the CT scan, it is well appreciated. And this is lung herniation. You know that lung herniation can be idiopathic or incidental finding and can also be secondary to trauma.
Ground glass.
Scleroderma.
Bronchiectasis.
Very good, very
Dilated
good.
esophagus.
And this is the scleroderma lung. The changes in the lung are those of interstitial lung fibrosis, but the dilatation
Esophagus.
of the esophagus
Esophagus.
with or without air fluid level is diagnostic of scleroderma. Very good. Thank you very much. وموفقين إن شاء الله بإذن الله تعالى.